Welcome to Caregiver Cast with Mary Elaine. Are you overwhelmed raising a family, working full-time, caring for a parent or grandparent? It can be challenging when you're doing it alone. Caregiver Cast helps busy, burned-out professionals reduce their stress and overwhelm to create a better caregiving experience for themselves and their loved one. Caregiver Cast brings caregivers together with experts who provide information in a variety of areas. In each episode, you'll get tips on topics such as finance, legal, medical, self-care, community resources, mindset, and more. We're here to make your caregiving journey a more rewarding one. Acquire the confidence and skills to be a more capable caregiver by implementing the resources and strategies from these expert thought leaders. Get a community of support, resources, and strategies for your caregiving journey inside the Caregiver Lifeline community. Visit caregiverlifelinecommunity.com. And now here's your host, Mary Elaine.
Hi, welcome to Caregiver Cast. I'm Mary Elaine, your host. My special guest today is Dr. Forrest Jones, who will be talking to us about helping you succeed as a caregiver. And that is so important. Before I formally introduce Dr. Jones, I'm going to give you some background information about him. Dr. Jones is leveraging advanced care planning conversations to help doctors connect with and care for their patients, and to help family caregivers find balance and satisfaction as they care for their loved ones. Dr. Jones has been a physician in family medicine for over 40 years. He has earned his doctorate at Northwestern Feinberg School of Medicine and completed his family medicine residency at Cook County Hospital, Chicago. When he became the power of attorney for his parents, he realized that he was not having advanced care planning conversations with his own parents. There were just too many barriers. And as a caregiver for his parents, he experienced challenges unique to family caregivers. So he decided and determined to do better. He discovered that advanced care planning conversations helped him connect with his patients. They revived my passion, curiosity, and empathy, and reduced his risk for burnout. They also, to his surprise, built my patients and their family caregivers' trust in him. Now he helps others facing those challenges, doctors, to have advanced care planning conversations that encourage them and family caregivers to not just survive, but to thrive. He is currently focusing on helping family caregivers to partner with their loved ones, partner with their doctors, and partner with themselves. In his free time, he enjoys time with his wife, Roberta, his children and grandchildren. And he also delights in good food, travel, and music. Welcome to Caregiver Cast, Dr. Jones.
Good morning, Mary. How are you today?
I'm doing fantastic now that you're here. I love the title of your talk about how you help caregivers succeed in providing care for their loved ones. So give us some idea. I mean, we have heard that you had your own conversations with your parents, and now you're working with females 50 years and older who are sandwiched between caring for children still in the home and a parent or grandparent, while typically working full-time. How did you come about using your experience with your parents to your mission today?
Yes, I'm very happy to talk about that. When I had that role in my family, I noticed that I was not having these conversations with my own patients. And having been trained in family medicine, one of the things that we always thought of was that these type of conversations were part of good comprehensive care. Easier said than done. And
sure
even now, right, exactly. Now, Medicare will pay for one visit a year for advanced care planning conversations.
Okay.
And I took note of that and thought, okay, I'm going to go ahead and just really start scheduling these visits,
Mhm.
dedicate, 40 minutes or whatever, or 20 minutes. Well, actually, we could do 40 minutes, actually.
Wow.
Right.
Nice.
But still, I found I was not getting it done
Mhm.
because, as you can imagine, sometimes I'm running late,
Yeah.
they're running late, or when they get there, there's something else that has more priority at the time.
Mhm.
And so advanced care planning conversations or end of life conversations were things that everyone would agree are important, but not urgent. And so they weren't getting done.
Mm.
And even when I started talking to some of my colleagues about, let's talk about how we can do more of these,
Mhm.
I found that we in primary care were not really feeling the pain when these conversations did not happen.
Whoa.
The
Mhm.
doctors who felt the pain are the emergency room docs or
Yes.
the intensive care docs in the intensive care unit or specialists like pulmonologists, cardiologists who
Mhm.
receive someone who's in very serious medical condition. And then they have to talk to the families and say, well, what are their wishes? What do you want us to do? How much does your loved one want us to do? Or should we try to do everything? Or should we limit this? And they're the ones who actually face these conversations.
I
Unfortunate. I would add it's unfortunate because everyone would agree, both our patients and we physicians, that we should be the ones, the primary care docs who are seeing you every 3 months, 6 months, sometimes more frequently. We should be having these conversations with you. And so that's um, unfortunate that wasn't happening. And I thought maybe I'll try to figure out how to address this. And that's what happened from here.
I can definitely understand. It must be really hard for a primary care physician or a family physician such as yourself, because you're under time constraints, under a lot of payer sources. So you have to see patients like every 15, 20 minutes. And I personally don't
Yes.
know how you can see 50 or 60 patients in one day. So kudos to
Yes.
you. So I can see where those conversations would be really limited.
Well, I would also add that most of us have not had training. I think that's changing more now,
Okay.
have not had training for these conversations. And there would be a misunderstanding. Uh, First, I myself, as I started to explore how I might be able to do better with this, noticed that when we talk about advanced care planning, we really think about a bad news conversation. So
True.
we're not really talking about planning ahead. Uh, what type of care would you want in the future, depending on your medical status? That might be 6 months from now, that might be 5 years from now, that may be 20 years from now.
Mhm.
But it's not about taking actions now. But a bad news conversation is one where you've had an event of some sort. We have to make decisions right now. We're putting together a treatment plan that we have to execute in minutes or hours.
Mhm.
What do you want us to do or not do? So they're two different conversations. And so they're really two different approaches. And I found that that was very helpful for many people, even just to look at it from that perspective.
True. And I would again agree with you. It just seems like a lot of families do not do this advanced care planning. And then an emergency occurs and nobody knows what to do.
Yes.
And they don't know the best medical decision to provide because they haven't had those conversations. So I agree. I see where they would be two separate conversations. However, it would be better for the caregiver as well as their parent or parents to have those conversations now, because we never know what's going to happen from day to day.
Correct. Absolutely.
So how did you approach those two different audiences?
Well, I decided, first of all, that I was going to focus on advanced care planning
Mm,
and redefine it, kind of get a new mental approach toward that. Now, obviously, we do have to have, as physicians, we do have to have skills for delivering um, a bad news conversation, for engaging a bad news conversation. Um, and because it's so urgent, that's a situation where you pretty much have to drop everything. So, for example, I might be going through my routine, and then Mrs. Smith is in the office. I see she's got an appointment. I kind of look over her records and I walk into the room, what I'm expecting to be a routine appointment, and there are 3 or 4 family members there that I've never met before. And so I walk in, and then I found out that Mrs. Smith had a stroke, or maybe she just got out of the hospital for a heart attack, and I wasn't aware of it. And they're coming, the family's here now because they want to know what type of treatments we're going to be going forward with. Ms. Smith, our mom, can't live by herself anymore. She was independent, she was living alone, and now we're working that out, and she's going to move in with daughter Jane, you know, and we're trying to get caught up to what's going on with her. And we want to be sure that all the medications from the hospital are, and so you see, that's the kind of conversation there. Or someone, this may happen where they've had some type of a fall or something, and they bring her to my office, and we find out that, oh, here's some vital signs that are changing. This is a problem. Let's call the ambulance. So those are some bad news conversations, you know, maybe a massive stroke and someone is maybe not even awake. They may be in coma, or they may not be that seriously ill, but they had been independent. Now they're totally dependent. And what can we do? And that's different where you have someone who's totally healthy. So you might come into my office, for example, and you're just getting a routine checkup. You just want a refill of your blood pressure medicine. I don't know if you have blood pressure, but hypertension. But let's say that you're taking blood pressure medicine and maybe something for acid reflux, and you just want a refill on your medications. And then I mentioned, well, you know, Ms. Petrucci, let's talk about your advanced care plan. And the first thing you're going to say is, Doc, what's wrong?
Right.
Is there a test that came back, or is there some news that you've heard that I've got a problem? And so right away you switch to a bad news conversation type of thinking.
Right.
That because I bring up advanced care planning, you're thinking there's some bad news, there's a tragedy about to happen, and it's going to disrupt your whole life, your family, and what are you going to tell the kids? And you know, will I still be able to? And all these things come up, and which is very frightening.
Yes.
Now, for the family caregiver, they'll have a similar situation where we're coming in they're bringing their mom or their father in for a routine visit, and I bring this up, and again, they'll wonder, Dr. Jones, what happened? Did a test come back? Is he going to have to go into the hospital? You know, and so we have to kind of say, well, you know, we're talking about comprehensive care. We want to be sure that we're not only taking care of you in the present, but looking forward to the future and get an idea of what type of plans you have in mind. What would you want us to do or not do to maintain a quality of life, not only now, but in the future and even toward the end of your life?
I can just imagine. Yes, I totally understand your patients. If you start talking about advanced care, yeah, your first immediate reaction is like, what is going on? But I like your approach, Dr. Jones, because you're very calmly stating that it's just a continuum of care, and that, you know, you as the primary care physician would like to prepare for all eventualities.
Yes.
Because you never know what may happen tomorrow or even that day, for example. So I really like the way you approach that. Has that really changed a lot in terms of how medical schools and how you have been able to help them instruct physicians?
I haven't had a chance to see much about that. I really haven't had a chance to really get involved to that degree with the training. But I would say this, and you probably will be tickled by this. One way that I would introduce this, so for example, I may have someone who's in their 70s
Mm-hmm.
or maybe even their 80s, and I want to begin this conversation. Um, Point one, to your point, it's really important for us as primary care providers to change our mindset, because if we really approach this calmly and matter of factly, then it makes it a lot easier for you to do the same. And you say, okay, doc, I'm leaving it up to you. Okay, what are we doing here? And so, for example, I have someone in their 70s or 80s, and I'll say, well, you know, 30 years from now, when your life is coming to an end, what do you want? What would you want done? Doc, I don't even want to live 30 years. I've broken the ice. I've broken the ice. And very often people have given thoughts toward these. And actually, I've found many times that my patient themselves are not as concerned about themselves because they really don't want a lot of extraordinary measures.
Right, right.
They're worried about their kids.
Mm-hmm.
They're worried about, there may be one particular one who they really are concerned how they're going to make it if I'm not here.
Right.
Sometimes there are family dynamics issues as well,
Mm-hmm.
where there's several children or other family members who are really dependent
Yes.
financially on this.
Right.
And so there are a lot of issues. And my focus is not on is only on the medical part
Mm-hmm.
of the advanced care planning, but of course there are financial and other parts to that as well that people do need to address, and they probably should consider seeing a financial planner or attorney or someone who can give them advice on those parts, because that can be very complicated and actually can impact the medical.
Mm-hmm.
Unfortunately, I've seen situations where the caregiver has a conflict of interest. So they are the primary caregiver, they're taking care of their dad, um, but they're only able to get dad's financial benefits as long as dad is alive. And so where the dad really is better served by just focusing on quality of life, making sure that they have comfort care, making sure that symptoms that might interfere with their quality of life are under control, but not life extending measures. And they really don't want those things, but the caregiver does.
Right.
Even if the dad is in a coma for 5 years, for them, that works. So you see conflict of interest areas that can come up. So unfortunately, that does happen.
I know. I've heard some of those horror stories too, and I would want to commend you for your sense of humor, Dr. Jones. Yeah, I love brings you. That's a great way to yeah, I think it's just to put people at ease and just let them know that you're their partner in the whole scheme of their life, and you want to make sure that you're honoring their choices.
Yes,
Which
yes.
may be different, like you said, than a family caregiver who is waiting for those or wanting those benefits as long as the person is alive. So yeah, I think that's really that really concerns me as well, when there's conflict of interest and people are just waiting for the person to pass so they could just have, get an inheritance or something.
Well, I'll use humor also, just to go back to that point, to help support the family caregiver.
Okay.
Because when, let's say, for example, you're the caregiver and you bring your mother in to see me for a routine appointment, I want to advocate for you too, because I see the family. That's what part of our training as family physicians is, to look at the family as a unit.
Mm,
So I found situations, and you probably would not be surprised to hear this, where oftentimes the caregiver doesn't feel appreciated. They feel like they're being taken for granted.
yes. Yes.
And that's unfortunate. And that can happen where you're not appreciated. You don't feel appreciated by not only the loved one that you're caring for, but
Mm-hmm.
even the medical professionals who you're interacting with as well. They may discount what you're saying about, well, I've seen her behaving differently lately, or she's been complaining about this or that. And then so you may say, well, mom seems to be losing weight. She doesn't seem to be eating, and then I might look to your mom and say, well, are you eating? And she'll say, oh, I feel fine. I'm not hungry. And I might be tempted to discount what you're saying because I'm believing her, and she's my patient. And sometimes there are HIPAA issues as well, where I can only explain certain things if you don't have permission to have me share everything with you. And so I may start to discount what you're saying, but I try to fight that. But one thing I would do as far as humor is I will tell my patients, say your mother, if you're the caregiver, that I want you to take care of her because I need her, make sure she comes back.
Right.
Or I might tell the caregiver, I'll tell my patient, well, she's my agent, so she's going to pick up her check at the front when she goes out, when she's checking out. And I will also check your blood pressure in the office. I will actually check the caregiver's blood pressure because, number one, I recognize the stress that you're under. I'm appreciating that, honoring that. I recognize that you're very tempted to not take care of yourself. You might miss your own appointments. When was the last time you saw your doctor? So I'm going to check your pressure, but I also want to send a message to your mom. I want to let her know I'm taking these steps here because I'm trying to make sure you stay healthy. And sometimes where I've actually seen my patient, say your mom, actually say things that let me know that they're kind of taking you for granted. And I have to say it, well, Miss Smith again, if Mary weren't here, where would you be? And they know that no one can take care of them. So for example, even here's the case where, and I'm sure some of your listeners have had this experience, where their parent won't let anybody else take care of them. They won't let, I don't want to cook. I don't want her cooking. I just want Mary's cooking, or I don't want, and so they really lock you into all these extra services, and you're trying to have someone else come in and help share some of the load, and your mom is just refusing anybody else. And so I'll start to advocate for you and say, well, if Mary gets sick, what's going to happen to you? Will you be willing to stay with that other sister, that other daughter? Or is your alternative to have to be in a nursing home or a aging center or something like that? And then all of a sudden they'll back off and say, let me start to take care of Mary, my daughter, because if I want her to stick around and be able to take care of me, I need to take care of her as well. And I keep giving these reminders for them.
Okay. I appreciate that because a lot of times, like you have mentioned, caregivers aren't recognized, they're not heard, they're not seen. And, they just feel that either the caregiver can sometimes feel like a martyr because like nobody else in the family will take care of the parent because they've all had a bad relationship with the parent. So nobody really wants to care for the person, the parent, because of that bad relationship. So I've heard like where someone really felt torn about taking care of their mother, even though they had a really bad relationship with her growing up, and her other siblings didn't want anything to do with her mother, let alone caregiving. So
yes,
I like you, I had to recommend that this person take care of themselves first. And until she could get to a point where she felt like she could help her mother, it would be really detrimental to her health and her well-being if she continued to take care of somebody that didn't really respect her.
Correct. Absolutely. Absolutely.
So,
Absolutely.
In addition, and I know caregivers also tend to not do self-care at all. And really that's, like you had mentioned, is so critical because they need some respite care. They need to have time for themselves or time for an agency to come in for a couple hours just to give them a break. And it's just, I know that there's been some legislative changes recently about reimbursing caregivers.
Yes.
I don't think it really goes far enough about really understanding the stress, the overwhelm and burnout these caregivers go through. I had talked to one woman who feels like she's the only person that could take care of her husband, because she's had other caregivers come in and they don't meet her expectations, let alone her husband's expectations. So how would you deal with something like that?
Excellent question. First of all, you hit on a really important point, because right now the research is showing that being a caregiver for females is its own separate risk factor for health.
Oh, I didn't realize
Yes,
that.
it is a health risk factor, right? Because of the stress that it causes.
Yes. Okay.
Yes,
I
and
wasn't
so
aware
we
of that.
want to, right. And then as far as your other question, I would say that it does require a team approach, in which the caregiver would need to work in concert with the physician, because the physician is the one who can order different services and so forth. And hopefully your physician is someone, or provider, nurse practitioner, or so forth. They can order services that you need. We also have the authority to impress a patient or the caregiver, to make some behavior changes that they might not be motivated as much to do before that. But then we also need other types of services as a team working with us. So for example, definitely a social worker or a case manager needs to be involved, because they're aware of all of the types of medical and community services. And then sometimes we can't necessarily achieve a complete change of mind, but as we over time engage, we can maybe start making adaptive changes. And so we may not be able to flip a switch and everything is 100% the way we would recommend, but their family dynamics, their individual preferences, and so forth. And over time, we might find that we don't necessarily have to go 100% of the way. Sometimes 25% of the way is good enough. And basically, we're looking for good enough. Related to that, you mentioned there's some financial compensation options that are starting to come up. We need more respite options. That I think is probably key. And there's two parts of that. One, it's got to be a place, just facilities that are available. And two, they have to be facilities that are acceptable to the family and the loved one.
Right.
And sometimes there are very excellent service facilities available, but the family or loved one think in terms of nursing home. They think of these institutions and they get scared away. And a lot of these new facilities coming up now have that in mind, and they're trying to have more home-like settings, and trying to provide more of a personal care and approach, and a family of, like, you're part of our family, that type of thing. I know for my dad, thankfully, his wife found a place that was not far from where they lived, and so she started taking him there for respite periodically. And he saw it as like a second home, because he would come in, oh, Mr. Jones, you're back. And he just really enjoyed that attention. So that was so helpful. Yeah, that was so helpful.
Definitely.
By the way, can I just add this?
Oh,
One
sure.
thing I try to do for the caregivers I'm working with is really try to set a schedule. I really like to try to have them build into their calendar where
Yes.
they have a 3-day weekend each month, and every 3 months have, 3 days to a week or 2 weeks, and just build it into the calendar.
Oh, right.
And I find two reasons for that. One is having experienced burnout myself, and I'm sure you're familiar with that as well.
Yes.
Having experienced burnout, you don't really want to have to go there because the recovery is takes so long.
Oh,
And you're just not able to provide what you may be thinking that you're providing, but you're just really falling way short. Um, and I found that for myself, if I had some break time or vacation time coming up, it just really recharged my batteries just anticipating.
mm,
And so having that in the schedule on the calendar,
mhm,
I think for the caregiver, will give them a real emotional boost that they need. But also, I found that it's a good way to stress test your system. What I mean by that is, suppose something comes up and you, the caregiver,
mhm.
have to go in for surgery.
Oh,
You need medical care yourself.
mm-hmm,
Or you may have, like for my dad's wife, they were in Pensacola, Florida,
mm-hmm,
but her daughter and their family were in California.
mm,
And so her grandson was graduated from high school. Well, of course, she wanted to go to the graduation. And so there are times when you really need or want to get away for a period of time. If you built these respite
mm,
episodes in your schedule, you've had a chance to try out different places over
mm,
time. And so now you found a place, and also your loved one has gotten used to the idea,
mm-hmm,
because since it is scheduled, it's not just an emergency thing, but it's just built into the schedule.
mm-hmm.
They start to come to terms with this. And so then you've got confidence, they've got confidence,
Yes.
So
Mhm,
now you can get away, because if you don't have that set up, I've seen people, for example, require hospital service. They have to go to the hospital themselves.
mm,
Now they're trying to get out sooner than they really are
yes.
recommended. They might have gone in later than they were recommended. And the whole time they were there, they're worried about their loved one
Mm-hmm.
at home. And of course, that type of mental stress interferes with your own healing, because the immune system start to fight against your healing
Mm-hmm.
because of the stress and all the stress hormones and so forth. So if you had a way to kind of build in some other respite options,
Mm-hmm.
then you can feel confident and you can really focus on yourself.
That's fantastic advice. I really like that. I think every caregiver
Easier
needs.
said than done, obviously, because we don't have nearly enough respite facilities, quality facilities that we need. But I think there's going to be more coming online. So,
Um, well, that is a great anticipation about getting the help that caregivers really need, because in my own research, I found that 76 million more baby boomers will be retiring by 2030, and that's going to be 45% of our workforce, and there's going to be no one to take care of them. So there's got to be more legislation, more impact with like the healthcare providers and the health system itself to start providing those services, because otherwise it's going to be a huge crisis. And I don't really
absolutely.
want that to happen. So I hope that they get this respite care in. The other situation I find is that some healthcare providers are looking into taking care of caregivers, which is fantastic. I appreciate that. And even some employers are. However, I think that there needs to be more support. And I have been on the Advocacy Council of the National, or the National Aging in Place Council.
Hey,
And they did, I think this was part of the legislation that was passed like in March or April. However, more needs to be done. And we need input from physicians such as yourself to help make this happen, because it's just so critically important. Because I'm not sure, future generations really want to take care of their elders. And that is in itself, it's pretty frightening.
That is.
But I like the idea of scheduling in specific times every month, every 3 months, so that, yes, they can go somewhere, recharge, not have to worry about their loved one, and really do as much self-care for themselves as possible. Are there
Yes.
anything other suggestions that you have for caregivers, Dr. Jones?
Right. You've touched on some things. I think there basically seem to be three types. One would be, like you mentioned, financial support.
Yes.
The other is respite and other types of care relief. And then another is skills. Many
Right.
times
Yes.
caregivers will look up and now they have to provide types of care that they don't feel prepared or trained or aware of, that they would need these skills. And right now, I think most of the time, the skills they might get would be as part of a discharge planning process when their loved one is leaving the hospital.
Right.
And a lot of, depending on how well that's set up, sometimes some hospitals do it better than others, where they get pretty thorough training on the specific needs. And others may just more or less just give you a document and then you're kind of on your own. And hopefully the visiting nurse or visiting physical therapist or occupational therapist might help you otherwise. But skills are important.
Yes.
And the skills could vary, depend on just general skills in terms of, for example, how do you help someone out of their bed or out of a chair without pulling your back out?
Exactly. Exactly.
How do you actually manage medications? And how do you monitor medications and things like this? How do you manage certain behavior changes or problems? And then you got specific things that are particular to the particular chronic illness that the loved one has. I did mention behavior. That can be a huge part of dementia care.
Yes.
And that's probably the most challenging of all at this time. Certainly one of the most challenging types of care that our family caregivers have to give. Others may have more focused things like maybe just post-hospital, post-surgical dressing changes, monitoring drains until those things are out, certain things like that.
Right.
Many nutrition skills about that. That's a lot of reason for arguments between caregivers and their loved one is the food,
Right.
So, and the doctor may have prescribed a very specific diet that's not appetizing to the loved one. And then I've just seen, battles actually between between the caregiver and the loved one, because the caregiver is trying their best to coax the loved one to eat in this way. Sometimes the eating plan that the caregiver has is not necessarily medically required, but it's kind of the caregiver is thinking from what they've read and so forth that this is really the best thing. And so I find myself sometimes negotiating between the two. And I try, so we try to minimize the diet disruptions on the one hand, and we also try to, there's more of an effort now to reduce unnecessary medications, because so many people are taking way too many medications. They may have medicines that were started some time ago. There's really no need for them anymore, but they just keep getting them refilled. So if we can minimize unnecessary medication and also minimize diet disruption, that can really also reduce a lot of the fighting that family caregivers have to have with their loved one, and that can cause great frustration and can actually cause a lot of wear and tear on the caregiver as well. And so if we're looking out for the caregiver, we want to help them pick their battles and pick battles that they can win, pick battles that you can win. Yeah.
That's a good point. Very good point. You have brought up so many critical points today about how to help caregivers, and one of them is advanced directives. Another, like you said, choose their battles, look for respite care and self-care. Are there any other recommendations that you have for caregivers, Dr. Jones?
Those are pretty much the important ones, but you brought up something I definitely want to emphasize again is let's give caregivers permission to take care of themselves.
Yes, yes.
That you are the key person.
Mhm.
Matter of fact, my point of view is that you caregivers are really the head of the care team. The doctor is not the head of the care team. We can prescribe,
Mhm.
but we're not responsible for actually carrying out and implementing all the different pieces of the puzzle that are required
Mhm.
to have those orders fulfilled.
Right.
I'll write a prescription. I'm available for questions, but I'm not the one having to be sure that your loved one takes the medication, that they're not falling during the night when they're getting up to go to the bathroom,
Mhm.
that they're not wandering, that all of these things, that they're getting bathed, that their finances are covered, that all the arrangements are made for the services that come to the house, and you're setting up all these schedules and doctor appointments and trying to make sure they get to the doctor appointment. You're trying to do these around your own work schedule. You're the head of the care team.
Mhm.
And so it's important for us, not only for you to take care of yourself, but also to know how to tell us what you need. We're there really to serve you, although we may not act like it many times. And you may feel that we frustrate you more than we actually help you. But we want to be able to help you to actually navigate this. Our medical system is so complicated.
I agree.
Not only are the services complicated to arrange, but also the financing is complicated. And
Mhm.
so, you do need help, and don't feel ashamed. You do need to take care of yourself, and we want to help you do that.
Thank you so much for providing your wisdom today, Dr. Jones. This has really been extremely helpful because we've really touched on the major points. And then, like you said, I'd like to also reinforce the fact that family caregivers need to be trained, and they need to be trained specifically how to, do catheters, how to, do certain wound dressings and things like that. Not necessarily a portacap. I wouldn't go there.
Right.
That would be too
Right.
complex for anyone, a family caregiver, to even need to entertain at this point. But are there specific ways they can contact you, Dr. Jones? So if they have any further concerns or questions about what we talked about today, could you let our audience know how they can best reach you?
Yes, I would certainly invite your audience to go to my caregiverquiz.com site.
Okay.
And I have a series of questions that I have there to sort out what your challenges are, or maybe challenges that are not challenges, but so we can focus on what help you really would want to have.
Mhm.
Um, and I try to approach what challenges or interests you might have in terms of partnering with your doctor,
Mhm.
or challenges or interests regarding partnering with your loved one, so that you guys are working together and pulling together as opposed to pulling apart from each other, against each other.
Right.
And then partnering with yourself. That's a
Mm.
key thing. So I kind
Yes.
of sort out the questions so I could find out uh, where are you challenged, where would you like more help, where would you want more information. So you can go there,
Okay.
and then I'll be able to reach back out to you. But if you want to go directly to my website, to my email, it's fjones@caringn.com. So FJONES at caringn, CARINGEND, one word, .com.
Thank you so much, Dr. Jones, for being here. It's been really enlightening, and I hope that caregivers see that physicians are really, their partner, and not to see physicians or the healthcare system as, an enemy in any way, because you have certainly had even family physicians start this conversation about advance directives and to take that 40 minutes every year that Medicare provides to really have those ongoing discussions, because things do change over time and your preferences about your care may change over the time. So I'm really glad to hear that Medicare is doing that. So thank you so much for being here. I really appreciate it. Thank you.
My pleasure.
Thank you for listening to the Caregiver Cast today. Get a community of support, resources, and strategies for your caregiving journey inside the Caregiver Lifeline community. Visit caregiverlifelinecommunity.com. Get involved with the show. Send your email to mpetrucci2002@gmail.com. And we'll see you again next week for another episode of Caregiver Cast.